topic which is assigned to me is quite big, and each section will require 20 to 12 minutes each. So therefore, because of the time constant, I shall confine myself to the biomarkers in heart failure, and of course, the risk stratification will be included there. According to the NIH definition, the biomarker is a characteristic used for the objective measurement and the evaluation of normal biological processes, pathological processes, and the responses to the therapeutic intervention. Now, why heart failure biomarkers are needed actually? Heart failure and COPD coexist in approximately 30% of the patients, making diagnosis confusing. Breathing not properly studied reported clinical confusion in nearly half of the cases reported to emergency room with breathlessness. An echo can detect abnormal LV function, but that may not be the cause of breathlessness because almost 50% of the population with decreased LV function are asymptomatic. And of course, you need for the better monitoring of the patients receiving treatment for heart failure. The ideal biomarker is either highly specific or highly sensitive, reflects abnormal physiology or biochemistry. Prognosis is almost meaningful if the label is clinically actionable and should be used as a basis for the specific biomarker guided therapy. Biomarkers in heart failure are actually categorized according to the primary pathophysiological mechanisms like myocyte injury and myocyte stress, neurohormones, markers of the extracellular matrix remodeling, inflammatory mediators and markers of oxidative stress, and of course other biomarkers. And these are the huge list of the biomarkers which are related to the various pathophysiological mechanisms of heart failure. Objectives of the biomarker testing in heart failure is mainly for the diagnosis, for the risk stratification and screening, and for monitoring and therapeutic guidance. The biomarkers for diagnosis are mainly BNP and NT-proBNP, ST2, Galactin-3, and proadenomyodoulin. Biomarkers for prognosis are BNP, NT-proBNP, and troponin. Biomarkers to guide the therapy, mainly NT-proBNP, and of course, there are newer biomarkers. 2017 ACC/AHA guideline recommendations for the biomarkers in heart failure, the natriuretic peptides for the diagnosis, class 1 level A recommendation, for prognosis, class 1 level A recommendation, for pre-discharge risk assessment, class 2A level B recommendation, to prevent the heart failure onset, class 2A level B recommendation, and to guide the heart failure therapy, class 2B level B recommendation, and of course the markers for the fibrosis and markers for the this injury like troponin, like ST2, like Galactin-3 are used for the risk assessment, class 2B level B recommendation. Now coming first to the biomarkers for diagnosis, BNP and NT-proBNP are most extensively studied in heart failure. As a result of myocardial stretch, the BNP gene is activated and prohormone proBNP is produced. Natriuretic peptides have a potential beneficial actions in heart failure, reduce the sympathetic outflow, reduce vasopressin, increase sodium and water loss, reduce aldosterone level, reduce the renin levels, reduce hypertrophy, and of course, cause vasodilatation, reduction in the systemic vascular resistance, pulmonary arterial pressure, pulmonary capillary wedge pressure, and right atrial pressure. Natriuretic peptides provides both diagnostic as well as prognostic information. Currently, there are no differences in the diagnostic use of BNP and NT-proBNP. Of course, NT-proBNP levels are higher in acute heart failure. BNP is an effective biomarker to assess the prognosis and the risk stratification in patients with heart failure. A diagnosis of heart failure using a single measurement of BNP or NT-proBNP in patients presenting to emergency room with dyspnea is associated with short hospital stay and of course lower cost of hospitalization. Now for the diagnosis, the cutoff level for BNP, if less than 100 picogram per ml, heart failure unlikely. And if it is more than 400, then heart failure is likely, but there is a gray zone of 100 to 400 where you have to apply the clinical judgment or the echocardiographic evaluation. NT-proBNP less than 300, heart failure unlikely, and it is more than 450 at the age less than 50, it is heart failure likely. If it is more than 900 at the age of 50 to 75, then it is more likely, and age more than 75, the value goes up to 1,800. And this is the ESC guideline for the diagnosis and treatment of acute heart failure. And here they set different targets, the acute onset and non-acute onset. NT-proBNP less than 300 in acute onset, while in non-acute onset less than 125, while BNP less than 100 in acute onset and less than 35 in the non-acute onset to rule out the diagnosis of heart failure. Diagnostic accuracy of BNP is 90%, negative predictive value is more than 90%. Use of natriuretic peptides are mainly for ruling out the diagnosis rather than establishing it. And the PRIDE and the ICON study clearly showed a high sensitivity of NT-proBNP for the diagnosis of acute heart failure. And this is important, another marker, the MR4-BNP, which a value more than 120 picomole per liter is for the diagnosis of acute heart failure, which is more useful in obesity, old age, renal dysfunction, and of course the patients who are in the gray zone for the NT-proBNP or BNP. So here is the marker we can pick up the diagnosis. And cardiac troponin also plays a role in the diagnosis. In acute heart failure, troponin has been performed to rule out the myocardial ischemia as the primary cause. And in chronic heart failure, this transient or the persistent elevation of troponin is observed in absence of any obvious myocardial ischemia. So overall, natriuretic peptides and they will remain the standard diagnostic biomarkers for the acute heart failure. Now coming to the biomarkers for the prognosis, there are NT-proBNP, Galactin, and ST2. Mean BNP levels are very well correlated with the NYHA class. And this is the other study we clearly showed that elevated admission BNP levels are significant predictor of in-hospital mortality in patients hospitalized with acute decompensated heart failure. And the incidence of all-cause mortality and the first morbid event was significantly higher for the patients with the baseline NT-proBNP above the median levels than for those with the values below median. And higher pre-discharge BNP in acute heart failure is associated with increased death and the readmission. There is the importance of serial NT-proBNP measurement for the prognostication of the chronic heart failure or congestive heart failure. When the levels are high at the baseline and it remain high even after 4 months, then the mortality is increased to 25.6% and hospitalization 26.8% compared to the low levels. With the low levels and remain at the low, the mortality or the event rate is low. Prognosis after the Adhf treatment, if the NT-proBNP reduction is less than 30%, the mortality is more compared to the NT-proBNP reduction more than 30% after few days or few weeks or few months. Cardiac troponin also plays an important role in the prognosis. The patient with the discharge troponin of more than 23.25 nanogram per liter had significantly higher 90 days mortality and heart failure related problems compared to the lower levels, less than 23. Then this is the data from the RELAX AHF study with serelaxin. The baseline peak and the peak change in the troponin were associated with worse outcome, with the strongest association with 180 days cardiovascular mortality. Coming to the another biomarker, Galactin-3 is expressed by the activated macrophages, and it induces fibroblast proliferation. Elevated levels promotes a progressive fibrosis leading to stiffening of the heart. Galactin-3 is for the predict the prognosis in AHF and CHF, to predict all-cause mortality in general population, and predict heart failure after ACS. So these are the benefits of the Galactin-3. And the cutoff point to less than 17.8 nanogram per ml, the low risk, 17.9 to 25.9 nanogram moderate risk, and more than 25.9 nanogram is high risk. And it is to be reassessed after 3 months. And after 3 months, if there is a 15% reduction, then the prognosis is better compared to when there is a 15% increase, the prognosis is worsen. Galactin-3 consistently predicts the probability of rehospitalization in 3 studies, COACH, PRIDE, and the UMHC study, which clearly showed increased probability of rehospitalization with the higher levels. Coming to the another biomarker, the ST2, which is secreted by the fibroblast and cardiomyocyte in response to biochemical strain. And according to the 2013 ACCH guideline, ST2 is not only predictive of hospitalization and death in the patient with heart failure, but also additive to the natriuretic peptide levels in its prognostic value. So when it is added to the NT-proBNP. Single ST2 cutoff point less than 35. If it is more than 35 nanogram per ml, then the risk is high. ST2 is not affected by age, sex, BMI, etiology of heart failure, atrial fibrillation, and anemia. and mortality risk increases with the ST2 levels. In the PRIDE study, we showed high predictive value for the death among the patients presenting to the emergency department with dyspnea with the higher levels. And prognostic value of ST2 is highest compared to the other markers. As you can see in these bars, you can see the prognostic value of ST2 is highest compared to other biomarkers. Biomarkers for guiding the therapy, and we have data from the natriuretic peptides and the ST2. Heart failure management guided by NT-proBNP or BNP would be superior to the standard heart failure therapy alone. And these are the biomarker guided heart failure trials. A number of trials are there, with some trials having the neutral effects, some have a neutral effects with a positive trend, and some trials show the positive results. Natriuretic peptides guided treatment of heart failure reduces all-cause mortality in patients aged less than 75 years and overall reduces the heart failure and cardiovascular hospitalization. Meta-analysis showed a significant reduction in the mortality with the biomarkers guided therapy. As you can see in these trials, there's a forest plots who clearly showed the benefit. And this is the algorithm for the NT-proBNP guided actions in the different heart failure related clinical scenarios. When there is a risk factor for heart failure, the NT-proBNP more than 125 or BNP more than 50, then more frequent follow-up is required. And of course, you may require intensification of the existing therapy. In the ambulatory HF, if the natriuretic peptide levels are more than 30% increase from the baseline, then again you have to go for the more frequent follow-up and intensification of the therapy. But when the levels in the hospitalized patient, the levels goes down below 30%, then of course the patient can be discharged safely from the hospital. What about monitoring the progress? Biomarkers for monitoring the progress of the disease. ESC guidelines do not advocate the use of natriuretic peptides in the monitoring the progress of patients being treated for heart failure, stating that the insufficient data are there to recommend it. Now coming to the last issues, there's a multi-marker strategies in heart failure. The multi-marker approach based on the NT-proBNP, troponin, and ST2 better identifies the heart failure patients at risk for the recurrent hospitalization as compared to approaches entailing just one or the two of the biomarkers. Multi-marker approach is useful in screening. They're also useful for the risk stratification, and BNP and Galactin 3 have increased the sensitivity for predicting the death or readmissions in heart failure patients and increased mortality with the multi-marker profiling in acute decompensated heart failure, and increased mortality also with the high multi-marker score and additive value of ST2 plus NT-proBNP in the long-term prognosis, which has also been documented. Now coming to the single slide, the biomarkers in heart failure preserved ejection fraction. All biomarkers which are raised in heart failure with reduced ejection fraction are also raised in heart failure with preserved ejection fraction. Although the sensitivity of these biomarkers is slightly lower, but it still has a high diagnostic accuracy, particularly ruling out, useful for predicting the risk of development of heart failure with reduced ejection fraction in asymptomatic patients with risk. Now coming lastly to the important issue about the importance of biomarkers for the stratifying the risk by the risk calculators. And we have recently this Barcelona BioHF calculator, which is a scoring system that incorporates available biomarkers reflecting different pathophysiological pathways, better allowed the individual prediction of death at 1, 2, and 3 years. And they have incorporated NT-proBNP, highly sensitive troponin, and ST2, the markers of myocardial death, stage, markers of myocyte injury, and of course the marker of the myocardial fibrosis. They are all included here. And the calculator provides the risk for all-cause death, the risk of heart failure hospitalization, and composite of the death and hospitalization, all of them really up to 5 years. And this is available online. So takeaway at the end, use of biomarkers in the management of patients with heart failure has increased tremendously over the past few years. Currently, the natriuretic peptides are the most commonly used biomarkers and helps in the diagnosis and prognostication, and of course, the planning the therapy also of the patients with heart failure. Galactin 3 and ST2 have a more prognostic value than diagnosis. And there are many new biomarkers currently under investigations, and results are evaluated to evaluate the different pathophysiological mechanisms. So biomarkers will make the bad doctors worse and the good doctors good.
Okay.
Thank you very much.